Thank you everyone for joining our second Heart Cafe of the day. It will be a very important discussion around women and cardiovascular health and how we're shaping the way for the future of better health for all women. We have a very esteemed panel of experts this morning. I'll let them introduce themselves one by one and then we'll get started with a very insightful, interesting discussion.
So my name is Dr. Athena Pappas. I'm the Chief of Cardiology at Brown University. I'm a past president of the ACC and current board member of World Heart Federation.
Hello everybody, my name is Adriana Puente. I am from Mexico City. I am cardiologist and I'm involved in prevention and cardiovascular disease in women.
And hi everyone, my name is Martha Galati. I'm a cardiologist at Cedars-Sinai in Los Angeles, California. I'm the director of cardiovascular prevention as well as the associate director of the Barbara Streisand Women's Heart Center.
Thank you very much. And my name is Lana Raspail. I'm the science program manager at the World Heart Federation, and it's so great to see you all here. So cardiovascular disease remains the leading cause of death for women as well as men. So it's obviously on the top of our agendas. Yet, despite this, there are significant gaps in awareness, research, diagnosis, and treatment. And historically, cardiovascular care has been shaped by data, protocols that often don't account for female characteristics. And that leads to often underdiagnosis, undertreatment, and underrepresentation of women in clinical research. So we're really going to dive deep into these issues and hopefully come up with some solutions to combat them. So we'll start off with a question to you, Dr. Pappas. From your experience, what are the most significant gaps in diagnosing and treating CVD in women? Tough one.
Well, there's a number, and I know that Martha's going to talk a little bit about risk factors and symptoms, but some of the gaps still remain in the data and making sure we're collecting the data that is sex-specific. I think the other gap continues to be in making sure that all of our data can be risk stratified or adjudicated for both sex and race so that we have the information to inform our decision-making going forward. Also, I think in the diagnosis, it's also public awareness. We've done an awful lot in conjunction with World Heart and AHA in bringing awareness to women that they may have different symptoms, which we'll hear about, but to recognize that it is a leading cause of death for women. So I think it's awareness as well as data.
Okay, and just on that, Dr. Galati, can you just elaborate a little bit on the symptoms that women experience and risk factors that it differ from heart disease in men, and what is the most overlooked and misunderstood risk factor for women?
Okay. Well, the symptoms for women, it depends what disease state we're talking, because cardiovascular disease is obviously more than one thing, but I think the one that we tend to talk a lot about when we're trying to increase awareness for women is ischemic heart disease. How would someone present if they're presenting with a heart attack or need further diagnosis to detect disease in the arteries? And actually a lot of our work in this contemporary era has shown that women actually, like men, the most common symptom that's present in 90% of men and women is chest pain or chest discomfort. The difference though for women is that women often present with additional symptoms. Chest pain's there, but it's not always the most important symptom that they experience. And also, we as physicians and people in the healthcare community, we somehow don't hear the women say chest pain. We even have evidence of this, of where women have already had a heart attack. We ask them, okay, did you go and seek out care for the same symptoms that brought you in? And this is from the Virgo trial. And they actually, more women than men actually sought out care, but they were more likely to be told this isn't cardiac. And again, in the Virgo, 90% of patients in Virgo study presented with chest pain or chest pressure. So I think it's important for us to be better about, removing our bias when we're listening to women compared to how we listen to men. Men can say, I put a nail through my hand, and we're like, oh, and you have some chest pain? And they get all the workup. So I also think it's, your second question about risk factors that differ by sex. I think that there's obviously a large number that we're learning about. And I think the way that I think about it is throughout the lifespan. So when you're meeting younger women, I'm a preventive cardiologist as well, so I sometimes meet young women, and then I'm asking different questions. I'm asking about, their age of menarche. I'm asking about polycystic ovarian syndrome. I'm asking about the fertility issues they might be dealing with. And if they've had pregnancy, then I'm asking about what happened in that pregnancy. None of those things happen in biological men. When we look at our risk scores, right, they don't have those variables in them. Even the new Prevent risk score that's being suggested has nothing sex specific. And I think that is why I dislike these risk scores, because I feel like, especially for the younger women that come to me, and then also that come to internists and gynecologists and family physicians, they're not as well detected that you're at risk if you're using that risk score. How do we change people when they're younger so that we lower the risk? I think that's what I'm always asking. What can we do? And we don't know all the answers yet about what we can do, but we can be definitely proactive in identifying the traditional risk scores that are modifiable and making women aware that they're at risk, and maybe helping them become more healthy if they aren't already, thinking about their diet, thinking about exercise, but also having a lower threshold related to cholesterol control and even blood pressure control, maybe being a little more aware that this is an individual at risk. You asked me, which one of those is the most pressing? I can't choose one, because I think right now we're just learning what's different. It feels like we're just learning what's different between men and women, even though many of us know there's lots of differences between men and women. And these sex differences, I think we need to know which one's the most predictive. And we need to know, again, I think we need research. Should we be intervening? Should we be able to find biomarkers that predict somebody's going to have preeclampsia? And there is obviously a lot of work in that area as well. But if we can intervene before that, can we prevent it even from happening? And then can they be lower risk? So I can't choose one.
Thank you so much. I mean, you talk about the research, and it seems like there's maybe a gap in the knowledge in research. Is there demand? Is there the need, or is there even sponsorship funding towards sex differences in CVD for women? Does it exist currently?
If you asked me in 2024, I had a different answer than now, at least in the United States. We don't know. We're writing up grants now, and we're taking out the word women, and we're saying people with, so that nobody throws our applications away right away. I think there is, though, a lack of research, and I'm sure my colleagues here can talk about it as well. You would see a late-breaking trial today had less than a third women, 27%. I always look at how many women are in the trial, and that was surprising. But then the later trial, the one on thrombosis, had more women than men, so that was good news. And of course, the Warrior was all women, so that we're getting there. And I think we should be optimistic, but we should keep pushing. We don't want them to forget, where are the women? As Dr. Pappas mentioned, one of the important things is when we have data, are we describing if there's sex differences? And I've heard the argument from men, it wasn't powered to look at sex differences. That's not why we're asking you to look. If there's a hint that there's a difference between men and women, maybe we design the next study a little bit differently. And I think those are the kind of questions we should be asking of our research and demanding of our research, whether it's from pharma, whether it's from industry.
Thank you so much. Dr. Puente, do you find that the cardiovascular disease trends are different in your region, Latin America in general?
Well, I think that cardiovascular disease is the same around the world, but I think there is a little difference in Latin American women, because maybe this is because of a prevalence of cardiovascular risk factors in Latin American women. We have a lot of incidents, high incidence about talking about hypertension, dyslipidemia, and diabetes in Latin American women. Some other factors related to social determinants, like social economic input, because cardiovascular disease is more prevalent in low and in middle income countries in Latin America. So we have a big challenge to improve social determinants of health and lifestyles in women. Another topic is that every 9 minutes, one woman is dying from cardiovascular disease in Latin America. And another important point is that cardiovascular disease is the cause of death 5 times more than breast cancer. So we have to change this point of mind in all the women, because now, at this point, every woman in Latin America, the majority think that breast cancer is the principal cause of death. And as you know, women are still dying from cardiovascular disease. So I think this is most important point of view.
Thank you very much. Back to you, Dr. Popes. In terms of disparities, how can healthcare practitioners better educate or be better educated to address the disparities that some women and special groups experience?
I think it's a great question, because first we have to have awareness that there is a difference. And there's lots of points of finding that education, whether it's at national meetings, online, the AHA websites, World Heart Federation websites. So understanding there's a difference, educating yourself, particularly around some of the newer risk factors that Dr. Galati mentioned around pregnancy, as we see younger women and how we communicate that to our internists and gynecologic colleagues, I think is really crucial, because I think there's still a gap in some of these early risk factors that aren't yet in our, they're in our guidelines, but not necessarily in some of the apps that we have for that, or risk factor calculators. So having the awareness is key, seeking out that information in national meetings, and then looking at research really carefully. And I think, again, as my colleagues have mentioned, looking specifically, is it a sex-specific issue? Was it actually raised? Was it discussed? Have you seen that across other studies where you could collect the data and put that together? If they've actually got the data, that's another point of educating yourself and then finding new research avenues. Looking at the social determinants of health, I think, as we've mentioned, how do we ask that of our patients and make sure that that data is collected so we understand what some of those gaps are? We might not be able to solve them, but at least we can advocate for them and help identify some of those.
Okay, great answer. Thank you very much. Back to you, Dr. Puente. What are some innovative approaches in ensuring equitable access to cardiovascular care for women in Latin America? Are there any existing initiatives that you can speak about?
Well, this is a great question and a difficult answer, because I think we have to do a lot of effort to create that kind of initiatives, because, for example, in Mexico, what are we doing? In Mexico, we are doing a lot of awareness, a lot of education to the general population and to the medical community to improve this gap between the health and the diagnosis and the best treatment in the cardiovascular disease. And also we are trying to do a lot of detections of cardiovascular risk factors and a lot of awareness, principally, yes.
Okay. Now, Dr. Galati, I just want to hear from you about the lifespan and how risk factors change for women in terms of pregnancy or premenopausal, post, during menopause as well.
Yeah, I mean, obviously for women, unlike men, I think, we have this continuous changes through our life. There's puberty, obviously, there's pregnancy if it occurs, and then there's menopause. And at each stage of life, as we all know, there's differences that can affect cardiovascular health specifically. What's interesting, if I just use an example of blood pressure, because it's something, we deal with every patient that we see. If you think about even the cutoffs that we use for blood pressure, why would it be the same for women compared to men? This is just how we do medicine, is we okay, this is what we studied men, and then we've decided this is also the same for women. And there's some interesting work that's been done by one of my colleagues, Susan Cheng. She actually had some data where they were able to map out the blood pressure throughout the lifespan. And what was interesting was the systolic blood pressure actually had a different trajectory in terms of its degree of incline in women compared to men, meaning that as we age, everyone's blood pressure goes up, but the slope was actually higher for women. And it just makes you start thinking. We need more data. I'm not saying we have the answers, but it makes you think that it wasn't being activated just because you went through menopause, but it's been increasing throughout your age. And maybe these thresholds that we use are different for women versus men because you think women do tend to have more stroke. Is it because we are allowing people's blood pressure to be higher than it should be? And I'm not saying we know the answers, but this is what we lack by not studying women. And so we need to, all of us have the work to do ahead of us to try to really solve these issues. That's just one example, because the traditional risk factors change throughout the lifespan. And of course, the sex-specific risk factors that could appear during that. And so we need to be thinking about that. When we're looking at younger women, as I already said, looking at the risk factors that are sex-specific. Looking at older ages, early menopause is a greater risk factor, whether it's surgical or natural. Also, when people have breaks in their period, from anorexia, which more women suffer from, when that happens to them, they actually are at an increased risk. But how many people actually ask about those particular, what we call functional hypothalamic amenorrhea? I haven't heard many people come or have that in their note when they're sent to me, that they're like, oh, I've identified somebody at higher risk. And so and the other thing that I think we need to do is, because as cardiologists, we tend to treat people when they have disease. And we need to partner with all of our colleagues who see women earlier to identify these risk factors. So it's not just awareness of women. We need to do that too, but we need our healthcare community to be aware and identifying women that might be at a higher risk.
On that, are there gaps that exist in medical training in relation to that?
Yeah, absolutely. I don't think that, we always talk about bikini medicine, right? Looking at the breasts and the reproductive system and ignoring the rest of a woman's health. And we're more than our breasts or our reproductive system. And so, but in medical school, often like when they refer to women's health, they're talking about those organs. They're not talking about the sex differences. And in medical school, it isn't, at least in the United States, I can't speak for anywhere else, but it's not a requirement to offer in every organ system the sex differences. And so at some schools, we're lucky where we've been able to introduce that in the curriculum. I'll tell you, I was at one university where I was insisting that it get in the curriculum, and they told me it was a special interest group and we could meet at lunchtime. So I refused to teach them prevention. I'm like, well, I'm not gonna do it if you think that that's a special interest group. So they need to learn, our medical students. If we bring out every medical student to understand these differences, we wouldn't have these gaps in care, because that's what we know. We know there's bias in our care, and there's bias, and there's also lack of knowledge. But if people are thinking about both sexes, and who didn't take pharmacology, where we were told women metabolize drugs differently than men, and pregnant women metabolize them different. And yet when we study the drugs, we only predominantly put men in those trials. We're not going to learn the differences till the drugs are on the market and we're using them. And then we're like, oh yeah, women are having more arrhythmias. Oh, women don't tolerate this medication. This is because we're not following what we learned in medical school, in my opinion.
It's really interesting. And I suppose, the awareness is there, the knowledge is there, the research is up and coming, but there needs to be a bit of a shift in terms of policies in relation to this as well. So on that, Dr. Popes, can you let me know what policy changes or systemic shifts you believe are the most urgent needed to improve cardiovascular outcomes for women?
I'll try to stay away from politics for now, but it's hard to. So we clearly need to, honestly, as scientists and people who are caring for all of our patients, half of whom are women, continue to advocate, and advocate strongly, that We need to be able to understand all the data in women. We need to be able to say the word women in our research and in our proposals, and not allow that to be silenced, because we won't have that data. We won't be able to answer those questions. So I think the policy has to be clear, both on a local, a federal, a national, and at an international level. I think both the WHO, WHF, ESC, and others have a great platform to continue to advocate globally of what's best practice. So I think we have a number of examples of that. The Lancet Commission was another example where a group collaborated around women's health. So I think elevating that outside of individual local politics can help us mandate that we see that mandate for education, both in the public sphere at an earlier age for sure. And I think we see that both in any kind of training, in high school, and even for children to understand prevention pretty early on, and we know that they're receptive to that. So there's lots of places to advocate locally that doesn't seem quite as aggressive perhaps, and you can do that on a local level. So there's policy in your school systems, there's policy in your medical school, there's places where you can help make a change, I think as Dr. Galati advocated for. And then on a larger scale, continue to advocate not only for the data, but for the awareness. And I think the education starting early on, continuing in medical school, and then continuing medical education in a place like this. It shouldn't be, a special topic. It should be embedded in what we're talking about.
Absolutely. So we have a great audience here who I believe would have some questions for all of you. Put your hand up if you'd like to ask one of the experts a question.
Hi, I'm Sharon Mulvey. I'm from Canada. Formerly was at Mayo Clinic for many decades. This is such an important topic, as we all know, and it's not a special population, and it's just not as special. We represent more than half the population, as everyone is fully aware. I think I'd like to just emphasize the point about training and education, because I think all of us that run women's heart clinics, our biggest desire is that we won't need to have women's heart clinics in the future, because this knowledge would be fully available and sustained in our practices. And I would just like to share that we do have in Canada, when I went back, it's a bit smaller pool there, a bit easier to get people together sometimes. And we have an organization called the Canadian Women's Heart Health Alliance. It's CWHHA.ca. And we actually have all of these resource materials, because that seems to be the biggest thing, is to who has the time necessarily in these busy clinical practice days to go out and set up the talks and do all of this, to be able to develop programs for mainly education and training in your institutions. So these are all available free online, and it's very comprehensive. I think there are 10 modules in particular about the training and education, to be able to just slam dunk put that into the programs in your institutions at all levels. And this goes beyond just medical students, certainly in residency, addressing cardiobstetrics in particular as a definite gap, as well as in other allied health care, nursing schools, et cetera. So I just wanted to bring that point out. We still, we all collectively have a lot of work to do, but this is the World Heart Federation. So I think that the more we do internationally together, the further that we will be able to get to our goals and achieve those.
Yeah, I would agree that those resources that the CWHHA has put out there are free and accessible to anybody. I've had the opportunity of working with you on those, and I do think that we should be sharing a lot more, because I do think that, no one wants to start from scratch, and we started from scratch maybe earlier on, but now we should be sharing the resources.
Can I make this a conversation? Because I think this is great, in being able to share this education so that people can do asynchronous learning. And I think that's sort of the future as well. How do we change the conversation where you don't have to go because it's your interest to learn about it, but, because it's a little of preaching to the choir. How do we get a room full of men that are accessing that as well? What do you think?
I think that we have to do more frequently kind of this forum, because we have to increase the awareness to the community, to the population, and in that way we can reach more people interested in the topic. Because if don't do awareness, how can they know the topic and the importance of that?
But it is true when we look at this audience right here, I count about 4 men. Thank you very much for being here, all of you. You are seen and recognized. But we need more men in the room. And if we continue to make it, as someone said, a special interest or a special population, that's not going to help. In fact, when we wrote the chest pain guidelines that I was part of, we actually very intentionally did not create a special population. We did have actually special populations, but that's not where we put the recommendations for women. We put them front and center because we felt like they're not a special, they're special, but they're not so special. When you're 52%, you're the majority. So you should be front and center, and everyone should know those recommendations that we were making specific for women. But it's the same thing. If we, in a room, whenever it says women and cardiovascular disease, it ends up being a room very similar to this with a small handful of men, which we want, but we want more. And so we have to think about strategies. I think one strategy is to have some men sitting at the table, if you will, or on the couch. There is men out there doing great research on women and heart disease, and we should make it known that you do not need to be a woman to be doing research in this area or advocacy in this area, because it's all our issues. We all have women that we love, we all care about, we all have women patients too. And so the more that we become inclusive ourselves, it has been led predominantly by female cardiologists. It's true, this movement to get women in, and it's so important. But now let's think about how we can reach a little further.
Another question?
Add one quick thing in the dynamic response to, I think we have to incorporate it in our exams. Like board exams have to have a section that is clearly addressing the issues for cardiovascular disease that have sex-specific aspects. So that's a way to get more interest.
Yes, amazing, the audience is amazing, the session. I think one of the things that I agree, we are not a special population. We are different, but one of the things is the awareness. We have the population and the medical population failed in awareness. And I think it's very important the level of the school, and we need the government. And the government don't interest in this issue. We are in Argentina. We present to Awareness Day for Women, and they don't interested. And so I think the project will fail. And how to engage the government? We are from the United States, from Canada, for all. Working 25 years more.
I think one place that you can start, though, we've done this in the U.S. and it did help us initially. We'll see where we go in these coming years, but we found women legislators, so women in Congress, women in the Senate, and we approached them, and they were the ones that pushed the breast cancer bills, which were important, and made a change. It made funding changes in the United States by those women pushing for bills on research related to breast cancer. So we went to the same women and said, do you know that heart disease is the #1 killer? And then gave all the statistics. And then suddenly they also helped us bring things to make changes. They're not perfect by any means. We have a long way to go, but at least we had some voices. So I think the more you can get someone higher up, they'll make the noise.
Yes, but it's not the same. If you tell somebody you have cancer, it's different that you have risk to have an infarct. It's different. You don't feel the same. Nobody feels the same. and it's very difficult to make prevention. You maybe say it's the same prevention for both.
It's a difficult point of view because we are have to be keeping going to that point of view because we have to close this gap and trying to get to the government and try to get policies in each country and try to make some prevention actions to cardiovascular disease in women.
And I think also, getting to know your local journalists, and it can start small, but if you know journalists in your community, that will help create a story. So I went to Poland because they were wanting to talk about women and heart disease. One of them, actually, one of the physician's sisters was a journalist. So she actually interviewed me, wrote a great big story that I can't read because it's in Polish, but they said it made a difference. Like, it actually helped them get funding for some things that they wanted to do. And it can start small, but the more people are writing about it, the more that the lay people are hearing about it, the more that we talk about the stigma, right? Because you're right, breast cancer pulls at our emotional heartstrings, and heart disease, for some reason, it seems like it's your fault. And yet the risk factors are almost identical. And I just think we have to keep saying these things, like, why do we care more about that versus this? And all diseases are important that affect women, and we're not second-class citizens, and we need to know things about our health. And I just think we have to attack it from multiple levels. I think the red dress campaign, this is just my opinion, nobody else's, but I don't think it was that effective, to be honest with you. We've seen the numbers drop in awareness. Not everyone connected to the red dress. The pink ribbon, everyone knows all over the world what it means, right? But not everybody, layperson-wise, knows the red dress. Should we hire PR firms at some point if we ever have lots of money? Can we what is the right message so that we get it out there to the entire community, which is, of course, patients, but also the medical community?
So I agree totally. I think it's so. One of the things that we can do is to work together with the gynecologist and the obstetrician. Sorry, that's maybe the first contact with the medical doctors that the women have, so they can maybe take a message.
Thank you. We've got quite a few questions, so just a quick answer and then quick questions as well.
Hi,
so we can
just
get
a
as
quick
many as
question.
possible.
Hi, Dana. As a breast cancer survivor, I can tell you that through the entire course of my breast cancer, nobody discussed my cardiac health with me. And I think that's really fascinating. And I think that there's a big hole right there. When you have a captive audience as women, and maybe you're going to get your mammogram, there should be some education at that point of entry into the system that gives you a heads up that you have to look at that. Because when you go through this journey and no one even touches that piece of the puzzle, when they have you there, they're speaking to you, you're frightened, you're terrified, you're hyper aware of your body. This is the time when they need to be educating you. And the question to the panel is, how do we start the education that maybe those go in tandem? Since we've got so much money with the breast cancer, maybe there is some sort of policy change that the testing or the baseline can be done at the time of diagnosis or during a mammogram. How do we change the captive audience when we have women that need the information, not just on their breast cancer care, but on their cardiovascular care? And young girls, high school, college, I mean, people spend all this time on their apps and phones and TikTok, and they don't know the parts of their heart, and they don't know any of the risk factors. How can we do that? But maybe, again, in the breast cancer space, there might be a place to put that advocacy in place.
Well, I think advocacy, awareness, and maybe to include some campaigns to detection cardiovascular risk factors. And basically, I think it's an education, the best approach to this fight, to cardiovascular disease. And talking about that, we have to make a closer approach with the gynecologists and oncologists. I think we are on the way. with these new specialties like cardiologists, cardiostratrics, and we are going to fight this together. Yes. And another point of view is that awareness, because when we have a lady, a patient in our office that is, for example, hypertension, with hypertension, we have to ask about the cardiovascular risk factors maybe during pregnancy. We always don't do that. There is a lot of healthcare that doesn't do that. And we have to know that, because maybe this patient is the one that have maybe preeclampsia before, and now is a chronic hypertension patient.
Two more questions, but I'll just also elaborate. So World Heart Federation has a very strong following on Twitter and TikTok and Instagram, and we are trying to reach the younger audience so that they're more aware of these risk factors. But it is challenging, definitely. Next question.
Hi, thank you so much to the panel. My name's Abra. I'm a cardiology fellow at the University of Minnesota. So to go back to this concept that you had touched on earlier, of needing a paradigm shift of having more men have an interest in this topic, I would love to hear from the panel, from like a fellowship educational level, what strategies or recommendations do you have? Because I agree, my sense, even at my level of training, is that it's sort of assumed that this is a topic that a woman should have an interest in and be promoting. So beyond just having the odd lecture here or there on women's health, what recommendations do you have?
I think it's a really good point, and I think we have some program directors here. I see our program director from Brown. And it also gets at what Sharon was saying. We should have this in our boards, because we're often training towards the board exam, whether that's right or wrong. I think having some of this asynchronous learning, so even if you don't have experts, hopefully you do, but if you don't have experts in women's heart disease at your center, you could utilize some of these external lectures. But how you incorporate that, I think also not always making it a separate topic, embedding it in there, just like we should be embedding health equity and the social determinants of health. If we're talking about valve disease, what's the difference between men and women? Are there racial differences? So that we don't have a separate talk about race and a separate talk about women, but it's embedded in each of the different topics. That would be my suggestion.
I think also if you have a women's heart center, what it has become is that people can do a voluntary elective there, but it's not mandatory. It's sort of like prevention. It's not mandatory as well. So these are my two areas, and I think these should be mandatory. Like, I think everyone needs exposure to all areas so that they, and like you said, if it's part of the board exam, then people are more likely to want that education. So I think we just have to restructure things as well.
Hi, my name is Marcel. I'm a second-year resident. Oh, sorry. So actually, my intern year of residency, sorry, can you hear me? My intern year of residency, I was just observing a lot of my fellow residents and how we navigated cardiovascular conditions in men and women. And specifically, the area that I'm from in Fresno, it's the only tertiary center between San Francisco and Los Angeles. And so there's a lot of women that are predominantly affected with the cardiovascular conditions we see in women, like hypertensive disorders of pregnancy, Takotsubo cardiomyopathy, Minoka. And these were things that I noticed a lot of my fellow residents and we were not familiar with how to particularly treat women, and how, history taking, physical exam, everything is different because there's pathophysiological differences that should have been addressed in medical school. And so in our program, with my program director, we actually initially started with literature search. So we took a look at systematic review, we conducted a systematic review about existing cardiovascular specific programs for women's health that are out there. So in medical school, in residency, and in cardiology fellowship. And unfortunately, just looking through the literature, there's actually less than at least 10 programs that have been formally implemented, studied, evaluated, and published. And so I think there's a lot of work in integrating this into our curriculum. And that's something that we've been trying to do it in our own program at UCSF Fresno. We've been trying to start a program, but like like you guys said, we don't want it to be, a specifically like an elective or an extracurricular activity. But we've been trying to incorporate it into our academic half days. And so, everyone can listen, because I think as an internal medicine resident, a lot of us are even scared when we get a woman who's pregnant and how to navigate a lot of their conditions. But everything, history, taking physical exam, the management, the treatment is all different. And so I would love to hear your guys' thoughts about what do you think we should implement in that curriculum for internal medicine residents specifically?
Internal medicine. Well, yes. We have to create a great program in all the universities and the faculties of medicines, because this is the principal point of view about talking about education. And also to be conscious about the difference between women, because women have a lot of risk factors during all this lifespan. So you have to know that to create a better awareness and education. I think that.
So I think we're nearing the end. I'd like to hear just a response from all of you in relation to one key action you believe the medical community must take immediately to improve cardiovascular care for women.
I'm going to come back, given the time we're in, to advocating for sex-specific data and for taking it upon yourself to do something locally, because it's something that's in your control to do. So I think those are, I guess that's two, but it's around advocacy and doing something locally first.
That is, we have to work a lot with education, advocacy, awareness, and try to get close with our governments and to create the prevention programs, prevention strategies, using a multidisciplinary team. This is very important.
And I think I would just say, we should all be critically looking at everything, including research, and ask the question, where are the women? If they're not there, there's something wrong.
Thank you so much, everyone. It's been a wonderful discussion, but it doesn't stop here. Let's continue and let's work together to raise the awareness and improve cardiovascular care for women. Thank you.